Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Amber Williams. Today's episode features Dr. Daniel Morgensztern from the Washington University School of Medicine in St. Louis, Missouri, and Dr. Jonathan Strosberg from the Moffitt Cancer Center and Research Institute in Tampa, Florida. They will discuss poorly differentiated extrapulmonary neuroendocrine carcinomas and current treatment, as well as the potential role of DLL3 targeting drugs in the treatment paradigm. This episode is part of a larger educational program titled Research Focus in Extrapulmonary Neuroendocrine Carcinomas, Emerging Insights on Targeting DLL3. For more information on Dr. Morgensztern and Dr. Strosberg, along with a link to the larger educational program, please visit the show notes for this episode. Now, let's get started and hear what the experts have to say.
I'm Jonathan Strosberg. I'm a professor of gastrointestinal oncology at the Moffitt Cancer Center in Florida, and I'm joined today by Dr. Daniel Morgensztern, and we'll be talking about poorly differentiated extrapulmonary neuroendocrine carcinomas in general, and specifically about the potential role of DLL3 targeting drugs. So just as a way of introduction, when we think of neuroendocrine neoplasms, we're talking about a very heterogeneous category of tumors, ranging from extremely slow growing to extremely aggressive. On the one hand, we have well-differentiated neuroendocrine tumors that tend to be relatively slow growing. We distinguish between three different grades: grade 1 with Ki67 less than 3%, grade 2 with Ki67 of 3 to 20%, grade 3 with Ki67 greater than 20%. Now, those well-differentiated grade 3 tend to be fairly aggressive. But then on the other end of the spectrum is poorly differentiated neuroendocrine carcinomas. And you'll notice we use the word tumor to describe well-differentiated, even if it's metastatic, carcinoma to describe poorly differentiated. And those are extremely aggressive cancers. We can distinguish between small cell histology, which is similar to small cell lung cancer, and large cell histology, although hard to say whether that's really clinically meaningful or prognostic. Poorly differentiated neuroendocrine carcinomas are always high grade. The Ki67 is always above 20%, and in most cases, it's much higher than that, 70, 80, 90%. By poorly differentiated, we're referring to the morphology, which, unlike well-differentiated nets, does not resemble the normal endocrine cells of origin. So with well-differentiated nets, the cells tend to be arranged in islets or trabeculae. They're well organized with typical salt and pepper chromatin. With poorly differentiated neuroendocrine carcinomas, they're often pleomorphic, a high nuclear to cytoplasmic ratio, and often large areas of necrosis. Now, when we talk about neuroendocrine carcinomas in general, the large majority are lung neuroendocrine carcinomas, and specifically small cell lung cancer. In fact, more than 90% are small cell lung cancer. So extrapulmonary is roughly 10% of the pie. And it's very heterogeneous in terms of site of origin. So maybe about a third of those extrapulmonary originate in the gastrointestinal tract, another third originate either in the urinary tract or the female genital tract or the male genital tract. And then maybe another third of those are unknown primary. Within the gastrointestinal tract, the most common primary sites are colorectum and pancreas. Esophagus is also seen occasionally. Gallbladder is another potential primary site. Stomach. Within the female genitourinary tract, it's mostly cervix, but occasionally ovary. And then for males, prostate neck is something that we see relatively frequently, but it typically evolves from adenocarcinoma as it dedifferentiates, and sometimes bladder. So these are some of the sites of extrapulmonary neuroendocrine cancers. So usually pathologists can fairly easily distinguish a well-differentiated neuroendocrine tumor from a poorly differentiated neuroendocrine carcinoma, but it could be ambiguous in some cases. And in those cases, looking for different mutational patterns on next-generation sequencing can be helpful. So just like small cell lung cancer, we commonly see mutations in P53 or RB1 with NEX, sometimes SMAD4. Sometimes we see mutations that are common to adenocarcinomas from this corresponding organ, so things like KRAS or BRAF. for colon or pancreas, because in many cases it's thought that these cancers arise from the same cell of origin and simply acquire a neuroendocrine differentiation as they develop. On the other hand, neuroendocrine tumors tend to have characteristic mutations like MEN1, DAX, ATRAX. So those kinds of mutations indicate it's probably well differentiated, especially pancreatic NETs. Sometimes PET imaging can help. So metastatin receptor imaging is commonly done for neuroendocrine tumors, and those commonly lights up avidly for well-differentiated neuroendocrine tumors, much less commonly for poorly differentiated neuroendocrine cancers. FDG PET was probably not that helpful because you'd expect it to be avid or show hypermetabolic uptake in well-differentiated G3 tumors. So FDG PET will almost always be positive for a poorly differentiated neuroendocrine carcinoma, but also sometimes positive for an aggressive, well-differentiated NET. There's also a mixed histology cancer. It's called MNN, mixed neuroendocrine, non-neuroendocrine carcinoma. Used to be called manic, mixed adenoneuroendocrine carcinoma. The strict definition is that at least 30% of either the neuroendocrine or non-neuroendocrine carcinoma can be identified by the pathologist, although whether it really needs to be 30% to meet this diagnostic criteria is not completely clear. And it, again, reflects the fact that many neuroendocrine carcinomas originate from similar precancer cells to adenocarcinomas, and there can be two branches of differentiation. As far as prognosis, just like small cell lung cancer, extrapulmonary neuroendocrine cancers are highly aggressive cancers. They're usually identified in a metastatic stage. In many cases, the performance status is too poor and even a diagnosis to initiate treatment, and patients who don't start treatment generally have a life expectancy of less than 2 months. The median survival for all comers is about 7 to 8 months, but obviously varies by stage. So for local stage, it's, according to SEER database, it's about 20 months for local, about 14 months for regional, and about 6 months for patients with distant metastatic disease. So the treatment for extrapulmonary neuroendocrine carcinomas has been borrowed from small cell lung cancer traditionally because they're histologically similar, although there are differences. For example, we all know that small cell lung cancer is almost 100% associated with smoking. That's not the case for extrapulmonary neuroendocrine cancer. So we're not talking about exactly the same malignancy. But in any case, the standard first-line therapy has been platinum etoposide for several decades now. And the outcomes tend to be quite similar with cisplatin or carboplatin. There is data that switching etoposide with irinotecan results in more or less the same outcomes. So the response rates are typically 30 to 50%, maybe a little bit lower than small cell lung cancer. The optimal number of cycles is unclear. For small cell lung cancer, it tends to be 4 cycles. We're not sure whether that's true for extrapulmonary, and in some cases will continue beyond 4 cycles, although most patients can't tolerate much more than 6 cycles. The benefit of adding a checkpoint inhibitor like atezolizumab has been demonstrated only in small cell lung cancer. We're conducting a randomized trial in extrapulmonary neuroendocrine cancers to see whether there's similar survival benefit in this population. It's not been determined yet. There have been single-arm studies of adding checkpoint inhibitors to platinum etoposide, but it's hard to know whether it truly benefits patients based on single-arm studies. As I said, the platinum etoposide combination was borrowed from small cell lung cancer, but of course we use our own platinum-based regimens in gastrointestinal cancers. Just tends to be oxaliplatin more often than cisplatin. And there is some retrospective data suggesting that FOLFIRINOX, a combination of 5-FU, oxaliplatin, and irinotecan, might have encouraging outcomes in gastrointestinal NECs. And we're awaiting data from a randomized phase 2 study that's comparing FOLFIRINOX to platinum etoposide. Beyond first line, there's really not much that has been promising. If there's been more than a 3 to 6 month interval of benefit after first line platinum etoposide, we tend to resume the same chemotherapy. But other options include FOLFOX, FOLFIRI, sometimes we use capecitabine temozolomide. There is data suggesting that the outcomes are fairly poor with all these second-line regimens with median survivals of approximately 6 months. There was a small prospective study looking at NAL-ERI and 5FU that showed an overall survival of 6 months, and another a negative study that showed that adding bevacizumab to FOLFIRI didn't result in any overall survival benefit. There are also anecdotal-based reports that in patients with targetable mutations like BRAF, which are fairly uncommon, targeted treatments might be somewhat beneficial. As far as checkpoint inhibitor therapy in the second line, there have been studies suggesting that single agent checkpoint inhibitors are relatively ineffective. There's been mixed data with combinations such as ipilimumab, nivolumab. One very small prospective study in EP-NEXT showed a response rate of 26%. Other similar studies have shown lower response rates. And in our experience, it's really a very small percentage, more or less 10%, that experience long-term benefit from combination immunotherapy. So guidelines like NCCN indicate that these are an option, but it's mostly because the chemotherapy is so ineffective in this setting. For early stage tumors, which are relatively uncommon, data is even more limited. The guidelines generally recommend multimodal therapy. Surgery alone is clearly inadequate. So we generally recommend at least 4 cycles of either neoadjuvant or adjuvant platinum etoposide, and in some cases, the local regional treatment should be radiation rather than surgery. That seems to be the case for esophageal neuroendocrine carcinomas or other locally advanced primary sites. In some cases, we do trimodality treatment, surgery, radiation, and adjuvant therapy. But this is all based on anecdotal data and theory rather than prospective studies. So to conclude, thus far, the progress in management of extrapulmonary neuroendocrine cancers has been extremely limited, and the standard of care for stage 4 disease remains platinum etoposide, and the role of checkpoint inhibitors in unselected patients is debatable. So there is an urgent need for new therapies, and one promising new direction are DLL3 drugs targeting using bispecific engagers, and Dr. Morgensztern is going to talk more about that. Thanks.
Hi, I'm Dr. Daniel Morgensztern, Director of Thoracic Oncology at Boston University School of Medicine. And my task here is to talk about DLL3, which has provided some hope for patients with small cell lung cancer, also for extrapulmonary neuroendocrine tumors. So DLL3 is a delta-like ligand 3. It's a member of a Notch signaling pathway, which regulates the cell fate decisions through 4 receptors, Notch 1 to 4, and 5 canonic ligands, JAG1, JAG2, DLL1, DLL3, DLL4. And in this pathway, Notch suppresses ASCL1, which is a key transcriptional driver of neuroendocrine differentiation. In this way, Notch activation is associated with suppressed neuroendocrine differentiation. Unlike other ligands, which are located in the cell surface, DLL3 is normally confined to intracellular compartments, mostly Golgi apparatus. Upregulation of SL1 neuroendocrine tumors leads to DLL3 overexpression and aberrant expression in the cell surface, where it inhibits Notch signaling in cis. And cis means the same cell, unlike the other Notch ligands, which are in trans from another cell, leading to ASL1 high neuroendocrine phenotype. So in summary, ASL1 is the driver of neuroendocrine differentiation. It is inhibited by Notch, which in turn is inhibited by DLL3. DLL3 is expressed in the majority of patients with small cell lung cancer and other neuroendocrine tumors. In a study recently published, DLL3 was positive in more than 90% of patients with small cell lung cancer, approximately 80% of other tumors. DLL3 is rarely expressed in normal cells, making it an attractive target for these neuroendocrine tumors. There are several ways to target DLL3 through antibody-drug conjugates, T-cell engagers, CAR T cells, and radioimmunoconjugates. A brief mention to ADCs, antibody-drug conjugates. There are many promising ADCs currently testing small cell lung cancer with some emerging data in extrapulmonary neuroendocrine carcinomas, which are called EPNECs. The main targets for ADCs in endocrine tumors are DLL3, TROP2, B7H3, and SEZ6. DLL3 was one of the first targets for ADCs with two drugs tested, robelpituzumab tiziran, ROBA-T, and SC002. But despite initial promising results, both drugs were discontinued development because of lack of improvement in outcomes compared to topotecan for ROBA-T and market toxicity from both, which has been attributed to the PBD payload. Despite these initial failures, those studies show that DLL3 is a valuable target, and there's a new generation of DLL3 ADCs with promising results. Of those, ZL-1310 has most data available. We have a promising response rate, above 50% in small cell lung cancer. Unfortunately for EPNECs, there is no data for the DLL3 ADCs. The only ADC with some data is ABV706, which is an antibody-drug conjugate targeting SEZ6, and we're using a topoisomerase 1 payload. Out of 9 patients with GEPs, gastroenteropancreatic neuroendocrine tumors, 2 responded, leading to a 22% response rate. In contrast, T-cell engagers have a completely different mechanism of action. The T-cell engagers bind to CD3 complex on T-cells, target antigen on tumors. This dual binding brings the tumors in close proximity with the T-cells, with the formation of immunological synapse, leading to MCH1 independent T-cell activation. The two T-cell engagers in the most advanced stage of development, tarlatamab and obrixtamig. Both are bispecific T-cell engagers targeting CD3 on T-cells and DLL3 on tumor cells. The first one is tarlatamab, which is composed of 2 single-chain variable fragments connected by a linker and a non-functional Fc just to increase the serum half-life. The initial studies have been done exclusively in small cell lung cancer, and the drug is already approved for this indication. Perhaps the most important study was the Delphi 304, where patients were randomized to second-line tarlatamab or standard of care, which could include lurbinectedin, topotecan, or amrubicin. Tarlatamab was associated with improvement in OS, median PFS, and objective response. There are several ongoing studies with tarlatamab, and a special one is called Ragnar, which is evaluating tarlatamab alone or in combination with FOLFIRI, patients with DLL3 positive, GEP-NEX, previously treated with a platinum-based regimen. I assume those will be patients that receive platinum etoposide. The second bispecific antibody is obrixtamig, which was until recently known as BI 764532, which, unlike tarlatamab, has an IgG-like scaffold. So the whole molecule looks like an IgG. The phase 1 study involved patients with small cell lung cancer, large cell neuroendocrine cancer, which I'll call LCNEC from now on, and EPNECs. The study had 4 different regimens, and the overall response rate for patients treated in 2 of those regimens was 21%. More interestingly, presented at ASCO this year, among the 60 patients with extrapulmonary NECs, the objective response rate was 40% to those with DLL3 high, which was defined as more than 50% of cells positive, and only 3.3% for those with DLL3 low. Obrixtamig received Fast Track designation for DLL3 expressing endocrine cancers, and the DION 5 is a study looking at obrixtamig in patients with small cell lung cancer or NECs. They should have received at least 2 prior lines, and they will compare 2 doses, followed by expansion cohort and most promising dose. There's also the DION 7, which is a phase 1 study evaluating carboplatin, etoposide, and obrixtamig as a first-line therapy for patients with DLL3 positive EPNECs, LCNECs, of NECs of unknown primary site. This is an important study which may actually define the role of obrixtamig bispecific T-cell engagers in the first-line setting. The other interesting DLL3 T-cell engagers will have other binds, And we have T-cell activating constructs, which we call them TITACs. The one in most advanced stage of development is called MK6070, which was formerly known as HPN32A. And in the phase 1 study, there were 13 patients with neuroendocrine neoplasias, of which 6 achieved response, which is 46%. Although the results are promising, certainly better than results from standard of care in those patients, there are some complications, such as potential complications, such as cytokine release syndrome, which usually is low grade and treated with acetaminophen, dexamethasone, or fluids, but some cases may be more severe, requiring tocilizumab. Another fear complication from bispecific T-cell engagers is the immune effector cell-associated neurotoxicity syndrome, or ICANS. This toxicity usually occurs slightly after the CRS, and it may present with confusion, impaired attention, motor weakness, dysgraphia. Patients should be treated with dexamethasone or methylprednisolone. Another way to target DLL3 is with chimeric antigen receptor CAR cells. These are synthetic receptors that allow T cells to recognize the tumor-associated antigens independent of MHC. There are 2 drugs, 2 CAR TCs. MG119 was the first one to be tested. 5 patients were evaluated. There was 1 partial response, 2 stable disease. The treatment was relatively well tolerated, but the study is suspended. The second one, which is still ongoing, is LB2102, another DLL3 CAR T, which is evaluated in small cell lung cancer and LCNEC. The phase 1 study was initially presented in 2025, 9 patients treated, 8 with small cell, 1 with LCNEC. The treatment was well tolerated, and there was 1 partial response. Another interesting way of CAR therapy is the DLL3 CAR NK cells. Those studies use NK92, which is an NK cell line, natural killer cell line, established in 1992 from a patient with Hodgkin's lymphoma. These cells have increased cytotoxicity compared to primary activated NK cells. They can be engineered as CAR and offer donor-independent, off-the-shelf options. The manufacturing will be ready. Patients will not have to wait that long. It's going to be tested only in small cell lung cancer. The fourth way to target DLL3 is with radioimmunotherapy. And one of the drugs is the lutetium-177 DTPA SC16. We just break down this drug. SC16 is the antibody. SC stands from Stemcentrx. That's the original antibody that was tested in the Ravati SC002 studies. The DTPA is the chelator to bind to the radioactive isotope, in this case, lutetium-177. This is the same radioactive compound that was used for lutetium dotatate and the lutetium bipivotide tetraxectan. There is no clinical data available at this time. A second radioactive isotope is the AC227 dotatate. Octreotate, here comes the name Tate, is a somatostatin analog that will bind to somatostatin receptor 2, SSR2. DOTA is the chelator, and actinium AC225 is an alpha-emitting radioactive isotope. This is currently tested in small cell lung cancer and other neuroendocrine tumors. So in summary, DLL3 is a very important target for neuroendocrine tumors. There are many ways to target. We're not so sure how those drugs could be used in sequence. At this point, most of the studies will not allow prior use of another mechanism of targeting DLL3, so we have to choose which one will be the most promising. Responses in second line and beyond seem to be better cross-trial comparing with the existing treatments for LCNEX. I have little question that at least one of the DLL3 targeting drugs will soon become one of the standard therapies in this setting. So how do you see ADCs or bispecific antibodies perhaps taking a place maybe in previously treated patients? Maybe it's a little bit too early to claim the first line.
the natural progression is to start in second line and beyond, and then try adding it to standard therapy in the first line. And I think that's what's going to happen with these bispecifics. As far as ADCs, as you pointed out, there hasn't been any significant success so far with ADCs targeting DLL3, but the bispecific and trispecific T-cell engagers look quite promising. So, there's so many cases where patients are really not in good enough shape to receive any second-line therapy. And so if we can add these drugs to first line, in addition to chemotherapy, or in some cases maybe instead of chemotherapy, there may be more beneficial to a larger population of patients.
I also think that it's very important that we have at least 4 reasonable targets: DLL3, SEZ6, TROP2, B7H3. So if someone receives a DLL3 ADC of topo 1 payload, that's over, right? But if they receive a DLL3 bispecific, for example, there's nothing to prevent the patient from receiving sequential ADC of topo 1 payload in one of the other 3 targets. So I can see at least possibly 2 lines of therapy that will be extrapolated from small cell to ap-next. The number of patients are small, so it's hard to have a 200-patient randomized study for ap-next, but having 20, 30 of some reasonable response is probably going to be enough. The Obrixtamig, for example, had patients with ap-next, and the fast track includes all neuroendocrine tumors that are DLL3 positive.
Yeah. Yeah, we definitely need to identify more targets, because we're actually planning to do a study on identification of targets in EP, NETs, and NECs. And so that would be interesting to see if we can duplicate some of the things that are being done in small cell.
To me, some of those targets, they should be overexpressed in all neuroendocrine tumors. For example, DLL3 is a target of ASL1, which is the master of neuroendocrine differentiation. The same is true for SEZ6. They have excellent correlation. So I would suspect there will be no difference.
Well, DLL3 definitely is expressed highly in poorly differentiated neuroendocrine carcinomas. The literature suggests it's not well expressed in well-differentiated neuroendocrine tumors.
True. Yes. NECs, not NETs.
Yes.
Because NETs, you can do other things, everolimus or peptide.
Yeah.
The NECs are where you borrow the small cell treatments for a specific reason, because the smoking and demographics are not the same. And the percentage of patients of early stage NECs is a little bit higher than small cell.
Yeah.
But in terms of differentiation and genomic expression, they are quite similar.
Right. I think extrapulmonary NECs in many ways are kind of a merger between small cell and the primary site. So, for example, I just saw gallbladder NEC recently, and it is highly expressing HER2, which gallbladder cancers do, or cervical NECs can be associated with HPV. So they're kind of a hybrid between the corresponding adenocarcinomas or squamous cell carcinomas and small cell lung cancer or large cell lung cancer.
Or perhaps early differentiation before the symptoms appear and before treatment is given. I also noticed that even the pattern of metastasis, very little brain metastasis, and they behave just like the adenocarcinoma counterpart. The gallbladder NECs go to the liver, go to the brain like the small cell lung cancers. Right. That's fascinating.
Yeah, very interesting.
Thank you, Dr. Morgensztern and Dr. Strosberg, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, Research Focus in Extrapulmonary Neuroendocrine Carcinomas, Emerging Insights on Targeting DLL3, please click the link in the show notes. And be sure to check back regularly for more episodes on important oncology topics.